So thanks for coming. It's my pleasure to introduce the latest in our webinar series. My name is Richard Heywood. I'm one of the trainee committee members and the representative for Yorkshire in the North East. It's my pleasure to introduce the webinar today on geriatric oncology, which I think we'll all agree is something that's becoming increasingly important in our daily practice. So it's my pleasure to introduce the first speaker, that's Dr. Nicolo Battisti. So Dr. Battisti is a consultant medical oncologist in the breast unit at the Royal Marsden. He's also the clinical lead of the senior adult oncology program there. He gained his degree in the University of Milan and has worked in the UK now for several years, and obtained a research degree at the Breast Cancer Research Division in 2022 with a thesis focusing on the management of common malignancies in older adults. So I think without further ado, I'll hand over to Dr. Battisti. I look forward to hearing what he has to say for us.
Yes, I'm a medical oncologist and I work at the Marsden. My disease-specific interest is breast, but my other interest is geriatric oncology. And I'm very happy to lead the development of a geriatric oncology program in our hospital. I'll spend a few words about this later. I'm also quite involved with the International Society of Geriatric Oncology, a multi-professional society of researchers and clinicians with an interest in the field. These are my disclosures. I will start describing briefly what are the challenges of managing cancer in older individuals, and how we can use geriatric assessment, which is something that we have learned from our geriatrician colleagues, to actually improve decision-making and the care of older patients with cancer. I will then also describe what are the benefits associated when you integrate these approaches in the routine care of this patient population, what are the care models available worldwide, and then draw a few conclusions. Cancer is a disease of aging. These are data from the Surveillance Epidemiology and End Results program in the States, showing that by 2040, they're projecting to have 73% of cancer survivors over the age of 65. And these are also nice data showing what is also the degree of increase in the burden of cancer in the older age group as opposed to the younger age groups. A 17-fold increase since 1975 to 2040 is expected to happen over the age of 85, a 10-fold increase in the age group of 75 to 84, a 6-fold increase in the 65 to 74 age group. And what this tells me is that really older patients should be a priority for clinical implementation, for research in oncology, and for education and the upskilling of the cancer workforce, because ultimately these are the vast majority of patients that we will see in the clinic, unless obviously do pediatrics. On the other hand, there are still quite a lot of gaps of knowledge on how we should best manage cancer in older patients. And it always strikes me that we've been knowing this since 1999, when Laura Hutchins published a very nice paper on the New England, looking at the recruitment of older individuals in the Southwestern Oncology Group clinical trials in the States. And she showed at that point that 25% of the patients recruited in these trials were aged over 65 versus 63% for the US cancer patient population, again, at that point, with quite striking also gaps, for example, for breast 9 versus 49%. And 15 years later, Arteria was one of the brightest minds in geriatric oncology, looked at the recruitment, again, in the National Cancer Institute sponsored phase 2 and 3 clinical trials in the States over a period of 10 years, 2001 to 2011, showing again only less than 10% of these patients at that point were over the age of 75, as opposed to 28% of the US cancer patient population. And again, this tells me that we have made very little progress over the years. We are no longer excluding patients from access to clinical trials because of chronological age criteria, but because of other criteria, for example, exclusion criteria pertaining with organ function, creatinine clearance, for example, comorbidities within the previous 5 years with cancer diagnosis, or because maybe trials are too complex, or because they have also endpoints that may be less relevant in the older age group. And this inevitably leads to treatment variation, because the applicability of the evidence that I'm using in the clinic every day to have discussion with patients and guide treatment decisions may be less robust in the older patient population. On the left, these are very nice data from the Bridging Age Gap study, which was an observational study among 56 breast units in England and Wales. Between 2013 and 2018, they recruited more than 3,000 women with operable breast cancer over the age of 70. The study included geriatric assessments, a baseline, and when we looked, for example, at almost 3,000 women undergoing surgery, even when we select a patient with high-risk disease, so those where potentially chemotherapy can be beneficial, and we selected those that are fit, only 27% of these patients were actually given chemotherapy, potentially highlighting some degree of undertreatment in this patient population. Age is no barrier to chemotherapy. It was another study conducted by Janine Mansi at Guy's Hospital on data from the SAC database and the HES database, 2013-2015, looking at the use of systemic anti-cancer treatment apart from endocrine therapy alone in large cohorts of patients with different malignancies. These are the data on breast cancer, almost 50,000 women with stage 2 to 3 breast cancer undergoing surgery. In these funnel plots, every circle represents a trust, which is plotted against the caseload on the x-axis and against the SACT treatment rate, adjusted for case mix, including, for example, comorbidities, performance status, and tumor characteristics on the y-axis. And while appropriately there is certainly a much lower use of systemic anti-cancer treatment in the older age group, over 70 versus the younger age group, it was quite striking to see the degree of variation in the use of chemotherapy among different trusts in the older age group as opposed to the younger age group, despite, again, case mix adjustments. It's very common experience in the clinic to see that all the patients are very heterogeneous. As we age, we become increasingly diverse under the selective pressure of a number of factors, including cancer, comorbidities, different health behaviors, because we live in different places in the world with different access to healthcare, social support, and so on. On one end, I may see all the patients that are very fit, with a longer life expectancy, a minimal burden of additional problems, competing risks of mortality, functional impairment, polypharmacy, a good organ function reserve, where the focus of cancer care could still be prolonging survival. At the other end of the spectrum, very frail individuals with a short life expectancy, a significant burden of comorbidities, polypharmacy, organ function impairments, functional impairments, where the focus of cancer care should increasingly shift towards quality over quantity of life. And sometimes telling the difference between these two categories of individuals is quite difficult. If you rely simply on performance status and so on, sometimes you have patients that are seemingly fit, but actually quite prone on experiencing undue side effects on standard therapeutic approaches. On the other end of the spectrum, patients that are seemingly frail, but actually quite resilient and able to tolerate adjusted treatment plans and benefit from them. Managing cancer in older patients is complex, obviously, because we see a gradual decline in the function of organs and systems with the aging process, but also because we have an increased prevalence of comorbidities, malnutrition, functional impairments, cognitive problems, polypharmacy, mood problems, lack of social support, and really make the balance between quantity and quality of life impacts very delicate. And it's quite common, unfortunately, to overtreat and undertreat also these patients. The solution for this is using geriatric assessment. This is something that I guess we will hear more about later during the webinar. But essentially, it's a diagnostic and therapeutic process that the oncology and geriatric oncology community has learned from our geriatrician colleagues, looking at domains that are relevant to the well-being of all the patients. Comorbidities, functional status, incontinence, nutritional status, polypharmacy, cognition, sleep, social support, mood, quality of life, hearing, vision, genetic syndromes. These are all questions that we should ask our patients in the clinic when deciding and recommending cancer treatment. And these are domains can be assessed with tools that have been used and validated also in the oncology field. And crucially, they should be linked with interventions, personalized interventions, typically within a multidisciplinary setting. And these interventions may include oncologic interventions, for example, adapting anti-cancer treatments when evidence-based, when appropriate, upfront dose reduction, different schedules of treatment, but also non-oncologic interventions addressing, for example, functional impairment, Let's think about strength and balance training, devices, home exercise programs, for prevention discussions, and so on. Comorbidities with a much closer engagement, involvement of caregivers and primary practice. Cognitive impairment is quite important to obviously assess decision-making capacity, but also to prevent delirium, also in the outpatient setting, limiting the complexity of treatment, and should also involve a thorough medication review. Psychological problems, again, we can trigger different interventions here as well: counseling, cognitive behavioral therapy, pharmacological interventions, and so on. Malnutrition with counseling, dietary recommendations, oral care, involvement, support of the patients and caregivers, supplements. Polypharmacy with a review of the medications taken alongside cancer treatments, and minimizing the complexity of medication as much as possible, and assessment of adherence. And social support, again, transport assistance, caregiver support, home safety evaluations, and so on. Some colleagues obviously may feel that genetic assessment are time-consuming, which is probably true to a certain extent, although I would argue that it's time very well spent for our patients. And that's the reason why the geriatric oncology community has developed and validated over time, also in the oncology field, geriatric screening tools to essentially identify patients that are suitable, are requiring enhanced care, so a geriatric workup alongside an oncology workup and integrated treatment plans, versus those that I can safely manage as younger patients. And these tools essentially are able to predict the outcomes of a geriatric or comprehensive geriatric assessment. They have different levels of sensitivity and specificity, obviously. This very busy table and is most widely used in the oncology field. And you may wish to use one or the other. It doesn't really matter as long as you use something that allows you to obviously identify problems, and as long as you use something that which is feasible in your specific setting. You might wish to think about what is, for example, patient reported, what's required, the input of a healthcare professional. You may wish to think about how much time these require, 4 minutes to 15 minutes, and so on. But I can also use additional tools to derive information that is very useful in cancer decision-making. For example, to estimate the life expectancy of our patients, you can access ePrognosis. This is freely available on this website, a repository of tools that are able to predict what is the mortality risk for each individual person at different time points, 1 year to 14 years, based on where the patient is being seen, outpatients, inpatient setting, nursing home, or again, hospice. As you can see, ePrognosis, these tools integrate typically a number of geriatric considerations: physical function, nutrition, depression, comorbidities, alongside obviously chronological age and gender, to predict again the prognosis of these patients. Typically, I haven't got the slide here, but one of the most widely used in oncology in the outpatient setting is the Suemoto index that allows you to predict the risk of mortality for that patient at 10 years. Predicting the risk, the benefits of treatment is also very important when informing discussion in the older patient population. Those of you that treat breast cancer obviously will be very familiar with PREDICT, which is available online, which has been investigated also in the older patient population by some colleagues from University of Leiden in the Netherlands, that showed that PREDICT is quite good, performs well for older patients if you look, for example, at shorter survival benefits at 5 years rather than 10 years, which makes sense in the context of a shorter life expectancy, and also for patients that don't have too many comorbidities or patients under the age of 80. And that's the reason why investigators from the Age Gap study, led by Linda Wild in University of Sheffield, came up with the Age Gap decision tool, which is, again, looking at answering the question, what is the benefit of surgery versus primary endocrine therapy for patients with primary breast cancer? What is the benefit of chemotherapy given after surgery for patients with, again, curable breast cancer? This tool was developed on UK cancer registry data from these two regions, West Midlands and Northern Yorkshire, over the age of 70, over 10 years on a large population of patients. Again, it's available online. And this is a tool which integrates consideration about the breast cancer, the receptor status, the grade, the stage, chronological age, but also the Charlson Comorbidity Index and functional information on functional status. I can tell you what is the benefit, for example, of, again, chemotherapy after the surgery at 2 at 5 years, so more meaningful and realistic time points in the older patient population. The third aspect is predicting the risk of side effects, toxicities on, for example, chemotherapy, which can be quite a challenging treatment in the older patient population. And this is the reason why the Geriatric Oncology community developed a number of what we call chemotherapy toxicity prediction tools. This is, for example, one of those, the Cancer and Aging Research Group CARG score, which was developed in 2011 and validated in 2016. You can see the reference here on JCO by Arturi and the group, and which is a model that essentially allows you to predict the risk of grade 3+ toxicities on cytotoxic treatment. So this is something that does not pertain to patients receiving immunotherapy or endocrine therapy or targeted treatment, only cytotoxic treatment. And as you can see, this model takes into consideration a number of factors, including chronological age, the type of cancer that we are treating, the dose of chemotherapy that I'm considering up front, a dose reduction or not, the number of chemotherapy agents, a mono versus polychemotherapy, lab values, hemoglobin, renal function, and again, geriatric domains, hearing, falls within the previous 6 months, IADS, ability to take medications, ability to walk 1 block, social activity because of related to the patient health. And essentially you assign a specific point score to each one of these items, and then you add them up and you derive a total score that tells you whether the patient would have a low, a medium, or a high risk of severe toxicities because of chemo. I found very beautiful also seeing that the investigators compared, for example, CARG with Karnofsky performance status that oncologists are far more familiar with, showing that actually the CARG score is much more reliable in predicting the risk of side effects on cytotoxic treatment. And again, these are discussions that I would typically have in the clinic with patients and saying, look, these are the benefits that I would expect from the 6 months or 3 months course of chemotherapy. This is the risk that you may have to end up in a hospital. What's your take? And this is incredibly powerful, empowers patients and improve so much decision making and shared decision making in this specific setting. We need to remember that this is also recommended, this approach, by guidelines. For example, the American Society of Clinical Oncology guidelines published on JCO in 2018, they're being updated right now, mandate that whenever we consider chemotherapy for patients over the age of 65, we should screen them for falls, depression, cognitive problems, malnutrition. We should estimate life expectancy, for example, with e-prognosis. We should predict chemotherapy toxicity with a CARG score, for example. We should assess functional status, and again, consider obviously comorbidities as a minimum core data set. There are SIO guidelines on, for example, geriatric assessments to consider or screening tools that you might wish to implement in your clinics, and NCCN guidelines that obviously get updated twice a year on all the other oncology with an awful lot of details on these aspects as well. So again, this is something which is guideline concordant. But why it's important to do this? Over the last 2 decades, we have learned that if we conduct geriatric assessment in the older cancer patient population, we can be much better in predicting prognosis, functional decline on treatment, risk of complications that we have seen. We can shift impact treatment decisions. We can find problems, emerging problems that are sometimes neglected by routine consideration, again, PS, performance status. Over the last couple of years, the Geriatric Oncology Committee has also learned that we can obtain very attractive benefits as well, typically felt more attractive by the wider oncology community, a reduction in the risk of severe toxicities and unplanned hospitalizations, an improvement of quality of life for patients receiving systemic anti-cancer treatment, and a reduction in the rates of intensive care unit admissions and prolonged hospitalizations for surgical patients. These are, for example, the two studies, phase 3 randomized clinical trials that demonstrated a reduction recently in the rates of severe toxicities for patients undergoing systemic anti-cancer treatment. GAP70 on the left was a study that recruited 700 patients over the age of 70 with incurable stage 3 and 4 cancer, initiating a new line of systemic treatment with at least one geriatric impairment other than polypharmacy. Conducted in more than 40 community oncology practices in the States, so we're not talking about the cancer centers, and this demonstrated a reduction in the risk of grade 3 plus toxicities for patients randomized, treated in centers randomized to receiving the outcome of a geriatric assessment performed by a geriatric oncology team at University of Rochester versus patients treated in center randomized to standard care. And this is perhaps because patients whose oncologist was aware of the geriatric assessment outcome were more wary of using upfront dose reduction versus those treated with usual care. But we know impacts in this palliative patient population on survival outcomes at 12 months. GAIN on the right was a study with a similar design, and this was a randomized study rather than a classic randomized study, recruiting patients over the age of 65 with solid tumors, initiating a new chemotherapy regimen in the city of Hope in Duarte, California. 600 patients randomized to, again, receive the input of the Geriatric Oncology MDT versus not. Again, patients had lower rates of overall toxicity, hematological and non-hematological toxicity when randomized to get the input of a Geriatric Oncology MDT, with also interestingly an high uptake in the advanced directed completion, again in the geriatric assessment intervention arm versus not. This is the third study, INTEGRATE, that was published this year, that was conducted in general hospitals in Melbourne, Australia, on 150 patients over the age of 70 with solid tumors of the LBCL, initiating a new line systemic treatment. And this is the study that demonstrated improvement in quality of life for patients randomized to receive the ongoing input of a geriatrician while receiving anti-cancer treatment versus not. Quality of life was measured with this ELFI score, which is the Elderly Functional Index derived by the EORTC C30 quality of life questionnaires, and perhaps not surprisingly, patients randomized to receive the input of geriatrician had better quality of life. But very importantly, this was also the study showing benefits in, for example, emergency presentations, a 39% reduction in the rate of emergency presentation, a 41% reduction in unplanned hospital admission, 24% reduction in unplanned hospital overnight bed days, and lower early treatment discontinuations due to toxicity. And again, this is something that tells me that probably these care models are also sustainable, because these are admissions that we are able to prevent and would obviously save resources, trust that then can be reinvested to support these care models. But what is available worldwide? If you look at the literature in geriatric oncology, essentially three main models, care models in geriatric oncology has been developed. The consultative model was, excuse me, the model that essentially is enshrined by the GAP70 study. You have an oncology team that obviously takes care of the oncologic intervention that refers patient to a geriatric, so a geriatric oncology team based typically on geriatric screening, one of those tools that we have seen. The geriatric oncology geriatric team performs CGA and then refers back the patient for cancer management to the oncology team with interventions recommended to implement. The shared care model, this is the INTEGRATE study model, where you have an oncology team that obviously takes care of managing the tumor, and the geriatric, so geriatric oncology team that works alongside the oncology team and is able to implement, for example, interventions over time rather than doing everything in one stop as typically you do in a consultative model. And finally, the comprehensive model, the GAIN study model, which is a model sometimes very difficult to set up, but it's quite useful because it allows the patient to receive oncologic and non-oncologic interventions under the care of the same team, typically including an oncologist that takes care of typical systemic anti-cancer treatment, obviously, working alongside geriatrics, surgery, clinoncs, nursing, pharmacy, physiotherapy, occupational therapies, dietetics, social work, psychology, palliative care, and so on, to really meet holistically the needs of these patients, this patient population. The first geriatric oncology services were set up in North America and in France. In France, the National Cancer Plan is supporting the creation of geriatric oncology units since 2006 across the country. In the States, oncologists and hematologists can dually train in geriatrics, which is great. There are now other clinics being, for example, implemented in other areas of the world that have been seeing the same demographic changes that we've seen in the so-called Western world, like in Latin America, Asia, Oceania. There are organizations working in this field, obviously SIOC, research group, the Cancer and Aging Research Group in North America, mostly the OTC. In Europe, there is all the adult council within the OTC. And ASCO has been doing an awful lot in the field of geriatric oncology, as you will see, or you can see on the website. ECO and ESMO are also increasing interest in these aspects. And there is a specific publication, if you're interested, which is Journal of Geriatric Oncology, published by Elsevier. So what we did last year at the Marsden, we were lucky to get some funding from the Cancer Alliance and partners to set up a geriatric oncology service, which is a consultative service with funding that allowed us to recruit a nurse, a CNS, physiotherapy, occupational therapists, dietetics, and the pharmacists working alongside a wider MDT, including psychology, speech and language, a welfare right advisor, safeguarding palliative care, and with close engagement with primary care community services. It's a consultative model, which means that we are using a geriatric screening tool, which is SOP3, which is a pragmatic tool developed at Moffitt Cancer Center in Tampa, Florida. It is a summarized version of a comprehensive geriatric assessment that asks patient the question about function, nutrition, speech and language, quality of life, psychosocial domains, and so on. Includes mini-cog, a cognitive screening test that takes no more than 3 minutes to complete. And there we are using to direct patients, refer patients from the medical oncology clinics, whenever they are over the age of 70, to the multidisciplinary clinic that takes place twice a week on Tuesday and Friday, where typically the patient would meet the team. Some may just need to meet the pharmacist, some may need to meet the whole team, PT, OT, dietetics, pharmacy, and nurse, to really come up with, again, an integrated treatment plan based also on their specific recommendations alongside systemic anti-cancer treatment. I wouldn't spend too much time on this, but this is essentially our CGA that we have implemented in our multidisciplinary clinic. All patients get a Charlson Comorbidity Index, a clinical frailty scale, some outcome measures of function, sit-to-stand, SARC-F to screen them for sarcopenia, grip strength, toxicity prediction with a CAR-BC tool for breast cancer patients if they are for cytotoxic treatment, and then additional assessment based on individual needs flagged by SOP3. So patients that are flagged to be malnourished, they will get an MNA. Patients that are flagged to have functional impairment, they will get CATS index, Lawton scale, time up and go, and the Golden questionnaire, and so on. Alongside blood tests to check thyroid function, HbA1c, vitamin deficiency, hematinics, vitamin D, and so on. This is us. Obviously, there is some fun time as well. And in conclusions, I would really say that I would really encourage you to read this beautiful paper that my mentor, Martin Exman, published in 2021, detailing what are the priorities to improve the care of all the patients with cancer at global level. But I think that it really applies also to our specific hospital institutions. It's all about improving clinical practice, obviously implementing care models to provide this patient with holistic care, interpreting the evidence available with a critical eye, developing guidelines to really fill the gaps of knowledge and based on what we know from the trial data, education, upskilling the cancer workforce with educational activities like this one, and that I'm very grateful for to the ACP, integrating geriatric oncology in the medical nursing and HP training. And I know that there are people on the panel that are working on this now, and educating also, raising awareness among the general public. And research, obviously, improve the relevance of clinical trials for all the patients. Use geriatric assessment to embed them in trial design, for example, to allocate patients to different experimental treatment based on fitness and frailty. Using technology where possible also to, again, get a better understanding of the individual needs. And finally, working together, the oncology workforce, along with obviously professional societies, patients, advocacy, policymakers, each one with their expertise, also to inform, for example, national cancer control plans at global level, because this is what the epidemiology tells us. And finally, we have learned over the last 2 decades to include a number of biomarkers when it comes to considering the tumor in our routine decision-making. Sometimes we are still stuck when looking at the patients at performance status and chronological age. They're very poor descriptors of their complexity. We should really use genetic assessment, consider life expectancy, organ function, comorbidities, quantity versus quality of life impacts, what matters to patients, and integrate them with tumor considerations. This is what I would really call precision medicine. These are some resources that I would encourage you to use if you're interested to learn more about the field. The SAIC website, the Cancer and Aging Research Group website, the Moffitt Cancer Center website, and the ACCC website. You can find an awful lot of genetic assessment that you can use on those websites, and you can use routine in your clinic. JGO already highlighted that, our official publication. I'd like to invite to come to Valencia to our next conference in November next year, our SAIC conference. And thank you very much for your attention. I'm very happy to take your questions.
Just a question from me. So obviously you started your program at the Marsden last year or earlier this year. Do you have any sort of results or data to show differences you've made to your population there yet?
Yeah. I can say that we have a huge database that we are collecting essentially to support the business case, because this is a project that is supported by our Cancer Alliance, and we are hoping to demonstrate benefits on a number of outcomes. Yes, we do. We are capturing toxicities, severe toxicity, grade 3+, and we start gradually from the breast cancer patient population. We now expanded in June to lung and GI, in September, renal melanoma. We have seen already an improvement in toxicities to grade 3+, despite we started very cautiously, which was great to see. We are capturing data on admissions. We have not seen improvements yet on admission, and my hypothesis, because we've been looking after mostly breast cancer patients at the beginning of the year, the first 6 months. And they are typically patients treated with very safe systemic treatment options. We are capturing quality of life, despite dealing with 80% of cancer with stage 4 inoperable disease, where you would expect a drop in the quality of life over time because of disease progression. We have seen that it has remained stable. And we are using all this evidence to essentially include in the business case to support the ongoing funding beyond year 1. We're also collecting data on patient experience, and that's always been very positive and from staff as well.
So a question from Ella and Daniel. How long do you think a new patient appointment needs to be to adequately assess these patients?
That's an excellent question. I don't have the answer, I'm afraid. I hope somebody from the panel will have. But in our experience, for the first 12 months, we had patients that may typically need no more than 20-30 minutes. Patients that need 3 hours to do a full CGA. There are patients that are very happy to have everything done in one single appointment. There are patients that get very tired. So you might wish to, split interventions up or assessment up in more appointments. I think it needs to be individualized for each person. This is one of the challenges when you set up a geriatric oncology service, understanding how long you can follow up on things, how and when to implement interventions and so on. And that's why I think you need to work with an MDT, including geriatricians, AHPs, pharmacists, and so on, because everybody has different expertise that really facilitates these sort of things.
Perfect. And one other last question. What advice do you have for other centres to try to secure funding time space to build similar models?
I suppose the recent trial data that showed the GAP70, the gain, and the integrated data showing those benefits in admission, toxicity, and so on are quite powerful from that point of view. I'm not aware that there have been I'm aware of some data from a single center in Toronto, but any other data, for example, supporting potentially the sustainability of these care models. But my hypothesis is that those data support, the sustainability of this model, because that's money that trust can save and then reinvest in paying the salaries of an MDT, for example. And second, making sure that, obviously your trust institution are aware that this is, again, guideline concordant. Whenever we do not do genetic screening for patients with older patients undergoing chemo, ASCO guidelines say that we should be doing that. So that's another powerful trigger, I would say, at least in my experience.
That's really good. Thanks.
Thank you.
Thanks for the questions. So I think we'll move on to the next speaker, who obviously Dr. Battisti is an oncologist. So we're moving track slightly to get, I think, a really valuable outside opinion from a geriatrician. We can often get stuck in our little specialty specific discussions, and I think it's really valuable to have an outside, a colleague, but from a different specialty, to give us their advice. So we've got Dr. Cassandra Ng, who's a consultant geriatrician with interest in oncogeriatrics at Manchester University Foundation Trust. She graduated from the University of Manchester and completed specialty training in the Northwest. She leads on the oncogeriatrics service at Wythenshawe and is part of the senior adult oncology team at the Christie. She's also co-chair of the British Geriatric Society Oncogeriatric Special Interest Group. So it's my pleasure to introduce Dr. Ng to give us a really valuable talk from a geriatrician.
Okay, so I think today I'm just going to, I'm absolutely delighted to speak to you about, well, how geriatrician's perspective of assessing and managing the older patient with cancer. I think traditionally as geriatricians, we tend to be quite doom and gloom, really. We tend to think that once you've got cancer, we should just be approaching it with a palliative approach. But I think increasingly with my time spent with oncology colleagues, I have realized how much cancer treatment has improved, and actually the toxicities, with the newer treatment options are probably not as bad, especially with things like the immunotherapies and stuff. But I realize as well that's more like a marathon, and chemotherapy is more like a sprint when it comes to treatment. So that's always in my mind. I'm trying to convince my geriatric colleagues not to give up on our cancer patients, and encouraging people to be interested within this area. But hopefully today I'll share with you our passion, our enthusiasm, and maybe just talk a little bit about why it is important. Nicolo alluded to earlier that if you're not a pediatric oncologist, you're probably a geriatric oncologist by nature. We'll talk a little bit about the role of geriatric services in cancer care, or even dedicated oncogeriatric services, which are starting to pop up over the country. And maybe share with you my thoughts about what the reasons to refer to geriatric services are, and share maybe one or two case examples, because we are quite limited in time. Maybe if I just talk to a case first to put this in your head, and then you realize maybe the relevance of this talk. Maybe let's just think about this 82-year-old man I saw in clinic last year. He presented initially with a fall, and it's not uncommon. Older people tend to present with a fall, and actually the fall is just kind of the first of many underlying diagnoses. He had dysarthria left facial droop in May 2021, was taken to the stroke center, found to have right temporal lobe infarct, but actually had low sodium, and as a result of that had a full CT scan, which eventually was found to have T4N3M, or small cell lung cancer. In the way of comorbidities, he didn't really have that much. He's got benign prostatic hypertrophy, hypertension, peripheral neuropathy, was an ex-smoker, some mild LV ejection fraction. As a result of his BPH, he has got urinary frequency, urge incontinence. The family talks a little bit about increasing forgetfulness, but actually manages quite independently. And my oncology colleagues tells me the treatment of choice here would be sequential chemoradiotherapy. But you can appreciate that he's got multiple comorbidities, and to optimize this man, you've probably got to refer him to all these specialists. Bear in mind as well the waiting times for this, and with small cell lung cancer, you probably don't have the time to wait. And you can imagine with regards to guidelines, you'll be implementing maybe 10 guidelines, some which conflict with each other. And this is not forgetting, this is on top of all his PET scans, pulmonary function tests, lung biopsy, oncology appointments, and all sorts. So just bear that in mind with regards to patient experience and the time taken for all this to be completed before you can even think about starting your treatment. We'll come back to that later. We'll just talk a little bit about the landscape. I think Nicolo's already talked a little bit about this, but the rate of cancer cases in those who are old. It's funny how actually these days as a geriatrician, we think 70s young and 90s old. And we know the survival, cancer survival is the lowest in the older population. Actually, 45.7% of the UK population have at least 2 long-term conditions. And it goes without saying that severe comorbidities is associated with higher mortality rates in cancer and cancer treatment. If you look at the projections of diseases in older people, although there's a push for preventative medicine and healthy aging, we will be seeing more and more diseases in our older population as they grow older. We know things like dementia is on the rise, but more relevant here is the rise of cancer cases predicted over the next kind of 20 years, from 2015 to 2035, to rise by 179%. So if you're not already a geriatric oncologist, you will be a geriatric oncologist very soon. Why are they different, you may ask? I think one of the things that we often see is cancer cases in older adults tend to be diagnosed in the emergency department when someone's fallen, and it's later on in their cancer journey. Also, on the other flip side, you get cancer screening programs, which is picking up cancers earlier, but then also picking up cancers in frail older people, and poses the questions as to, now that we've found it, we've invited them to this screening program, do we just leave it? What do we do? Do we exclude them? So there are more and more questions. Advancing treatment and multiple options now, as I talked about earlier, so it's no longer only chemotherapy, and the decision is actually quite easy at those stages that actually if you're not fit for chemo, there's no point doing anything more, just refer them to palliative care. But actually there's more than chemotherapy now, and with the advancements of cancer treatment, we need to think harder and assess an older patient more thoroughly. And of course, trials previously excluded older comorbid patients, although they are your main customers, main clients in cancer clinics. We know that older people do live with frailty. Frailty is a major issue these days, and I think these days you can't attend a geriatric talk without people talking about frailty, but it is not directly equivalent to performance status. And don't forget that older people often have other social aspects that are different from the younger population. Either they are already a carer for an older partner, for example, or actually they are, their social isolation, they live alone, especially females who tend to live or live longer than their male partners. So there is a high incidence of loneliness among our older adults. And also, I think, just to say some pictures here, I mean, older adults are a true heterogeneous group, and you can't just tell by looking at them. I mean, Mr. Singh at the top, if I didn't show you the picture of him running a marathon, you probably think he might be quite frail. But actually he ran the Hong Kong marathon at the age of 100. And of course, I think if you look at the picture at the bottom, there's a cohort of people, some using mobility aids, one in a wheelchair. It's really hard to assess whether one is frail just by looking at those pictures. We may have our own bedside assessment, bedside thoughts, but actually that lady in the wheelchair might be fitter than the rest of them. She might just have had, elective knee surgery, for example, and therefore needs to be in a wheelchair, not a true marker of a frailty status. So what does that mean for us then, for geriatric service, first for geriatric oncology? I think it all comes down to the fact that, we can't deny that older people, no matter how well you age, how well you look after yourself, they are more likely to present with geriatric syndromes. Sir Bernard Isaac here, who is a guru of geriatric medicine, defined geriatric syndromes as immobility, impaired intellect, incontinence, instability. So you tend to hear this. I mean, if you recall in your medical younger days, you tend to get this presenting complaints, increased confusion, UTI, falls, some of the most common reasons people end up in hospital, but they're really not always just the diagnosis. The UTI always ends up to turn up to be some sort of, heart failure, something along those lines, and you just need a more thorough assessment. But increasingly, the modern syndromes of geriatric medicine, frailty, sarcopenia, anorexia of aging, cognitive impairment, polypharmacy, and intolerance of medications. And I think, all this can be present in your cancer cohort as well. And how do we manage them? Some of it are reversible, others are not. And it's needing that holistic assessment to be able to tell the difference. We talked about screening too. I'm not going to go into full detail about screening. I think Nicolo already spoke a little bit about it, and Jess may go on to talk a little bit more. But just to say that, you know, in geriatric medicine, we've been using the clinical frailty scale for a long time. If you can't remember any of these pictures, I would encourage you to download the clinical frailty app, which is on the iPhone or Android, and it's free. It takes you through a series of questions, and you can come up with, you know, the most accurate frailty score. And to say that really we've known this since 2005, that the clinical frailty, the CFS is a good predictor of survival, good predictor of institutionalization with or without cancer. So what can geriatric services do? I think we must say to begin with that we're not oncologists, neither are we surgeons. So we're not going to cure the cancer. We're not going to help you. We're not going to make decisions about cancer treatment. We're not here to stop you from giving your cancer treatment. I think we're here to kind of really, really not be the superheroes, but to just kind of provide you with more thorough opinion, a thorough assessment. I think we've got the benefit of time, really. And it's that kind of balancing the scales, trying to get people as functionally independent for as long as possible and compressing the periods when they are functionally dependent, and at that point providing good palliative care. I think we're here to be the patient's advocate, the older patient's advocate. We spend years in training working with older people, and their wishes and their priorities may be slightly different. And I think it goes without saying that, you know, spending more time with someone, being able to talk through a whole wide range of issues, not necessarily just the cancer, does help improve patient satisfaction. And we do this by the comprehensive geriatric assessment. I think people often ask me what the comprehensive geriatric assessment is. Is it, you know, a tick box? Is there a way we do it? I think in geriatric medicine, everything's fluffy, and we don't really have many tick boxes or checklists or anything like that. Really, it's just about talking, and the comprehensive geriatric assessment is our skill set, our bread and butter, really, in geriatric medicine. We use this across all scopes of geriatric medicine. And it's not just an assessment tool, although the name talks about assessment, but it's an assessment and intervention, interdisciplinary and holistic assessment and intervention. And it leads into, you know, kind of going through all these areas: physical, socioeconomic, functional, mobility and balance. We might go back and forth depending on what the patient says. And then we come up with a problems list, and we then try to sort out intervention for each problem list, come up with a personalized plan of care, and regularly review it after the interventions. We sometimes build relationship with patients in clinic for 2, 3, 4 years. Unlike, you know, just similar to you guys, you maintain a long-term relationship with these patients. And the other thing we do is coordinating care. I think if you just think back about the beginning of the case that we talked about, you can see how many different specialists will be involved in their patient's care. Sometimes the patient go from appointment to appointments, and they get a bit confused at the end and say, what's more important? You know, the cardiologist will say the heart failure is more important. The falls team will say, stop the heart failure medications because you're going to fall. And actually, what is more important? And some of our roles as geriatricians through the comprehensive geriatric assessment is to kind of lay it out in order of priorities, not to say that none of them are important, but what's more important than others. And helping with that risk stratification. We've used this, and we know the evidence is there in autogeriatrics, in emergency department, front door geriatric medicine, surgical liaison, nursing home community geriatrics, in reducing length of stay, reducing unplanned admission, reducing institutionalization, and preserving independence. And there's no reason, therefore, for it not to work in oncology. And Nicolo alluded to earlier the effects of this in oncology setting as well. But of course, it is a whole team-based approach, and at the Christie's, I'm lucky to have the whole team with me. And we've got Fabio, who is the oncologist, me as a geriatrician. We've got a GP, we've got OT, CNS, and pharmacists, as well as a physiotherapist, and we all work very closely in delivering this comprehensive geriatric assessment to lung cancer patients at the Christie's. You may say, that's a really big team, how much does it cost? It's really hard again to say how much it costs, but I was just looking through NICE guidance and just giving you a bit of illustration. This is from 2015, though I can't find anything newer. So you can imagine with the inflation of 10% in the last year, this may all have gone up in price. But a CGA, they reckon, costs about £250. And I think the question earlier about how long it takes for us to do a CGA, it takes, certainly at least for a new patient, at least 45 minutes. at the very least, and can take up to, as Nicolo says, 3 hours. But that's, in comparison to getting patients to a nursing home, let alone, patient experience, you're paying £840 a week, or could be about £1,000 a week as well. A hospital bed stay, £222 a day. And it's not just about that night in hospital. We know that 10 days in hospital leads to 10 years of muscle loss, and they end up in a nursing home afterwards. So costs do quickly escalate. And if you are thinking about, setting up services and justifying costs, maybe this is a good slide to take away and say that if we can prevent unplanned hospital admissions due to frailty, then actually there will be a wider cost savings, maybe not to just your hospital trust, but generally to the NHS and social care. The comprehensive geriatric assessment should hopefully also provide more kind of thorough assessment into the frailty status as to whether it's frailty because of cancer or frailty prior to their cancer, because of course the treatment is different than if it's frailty because of their cancer solely, then you may want to get on then and do the cancer treatment. But actually if it's prior to the cancer, then it is about looking at optimization, reversible causes or not. And as I said earlier, I think, cancer, chronic diseases, disability and frailty do interplay, and having the presence of cancer does push you into a more frail state. So the general principles of treatment in my head, and this is probably a simplistic way of looking at things, is really broadly categorizing people into fit, maybe, so the pre-frails or the frails with reversible risk factors, and then the severely frail, which really the best care that we can provide them really is palliative and best supportive care, focusing on quality of life and supporting their preferred place of care and death. And with the fit cohort, proceed the treatment, but then obviously involving other areas such as prehab for cancer to optimize their fitness even more. And of course, I think what we know is that throughout one's cancer treatment, especially an older person, the cancer treatment itself can make one frail, and people often can move back and forth between these boxes. And it's that constant comprehensive geriatric assessment to identify any room for further optimization. I think you're probably familiar with this, more familiar with this than I am, with regards to the general Macmillan recommendations with regards to improving people's fitness before treatment even begins to improve outcomes. And actually, and then that led to things like prehab for cancer, which has in itself demonstrated success in reducing toxicities. But I probably would want to say that in older people, we're not really talking about that getting people back to general fitness and health, but really it's kind of reducing functional dependence. And this line here, the red line right at the bottom, and not getting what you don't want to do, of course, is try to improve quantity of life at the expense of quality of life, and them ending up in institutional care. And that's usually due to functional dependence. And our older people tend to be around here, and during their diagnosis period tend to go downhill rather than a plateau. They tend to kind of become weaker and weaker. And sometimes with treatment, they just fall way beyond the curve, and you've got to stop cancer treatment early, and they end up in 24-hour care, which is not what we want. And, of course, we, together with things like optimizing exercise and nutrition or psychological support, we try to optimize people by optimizing their comorbidities, reviewing their medications, because we know polypharmacy in itself is a risk factor for falls, for example, or cognitive decline. Looking at proactive environmental assessments and putting in adaptations in place before one falls, because often the fall is what ultimately causes the domino effect of it ending up in hospitals, getting an infection, becoming more sarcopenic, more deconditioned, and then not fit anymore for any further cancer treatment. And then looking into social support. Often older people, I was in clinic a couple of weeks ago, and a patient said to me that, at the diagnosis of her initial lung cancer, early stage lung cancer, she decided to go with radiotherapy rather than surgery, although she was offered surgery because she was her main carer for her husband who has dementia. And actually now she's got a recurrence. She blames herself for it, for deciding to have radiotherapy rather than surgery, but she didn't feel like she had any choice. It's empowering people to make the right decision and making sure that we we try to support them in whatever decision they make. And I think, again, in a simple way, me looking at this about how we work together, your strengths, of course, in oncology with regards to improving quantity of life, treating cancer-related symptoms, treating the cancer itself, but ourselves in management frailty, advanced care planning, trying to prevent functional dependence, maintaining quality of life, and working together to strike the right balance for the patient. And just bear in mind that survival may not be an oldest person's top priority. They may have a lot of other priorities that they may wish to discuss. And it is that Jenga pieces is that trying to find out and fit bits and pieces into the right place and make sure they don't all topple over. Just one or two slides about CGA and treatment decisions. We know that CGA does influence treatment decisions, but I think one of the concerns that my oncology colleagues always say is that geriatricians stop you from having treatment. But just bear in mind that having a CGA and oncogeriatric assessments don't always mean not having treatment. They do, in this paper, show that there's an increase in patients having more intensive treatment, actually, based on obviously all the steps taken to optimize patients. So it's not just about stopping you from having your treatment. The CGA in cancer itself, it does predict morbidity and mortality, helps adapt cancer management to patients' fitness or frailty, but more locally, at King's Guy's and St. Thomas's, the pioneering GO service have shown that the CGA, the MDT delivered CGA leads to more older people completing chemotherapy as planned with less toxic or less severe toxicities and less requiring treatment modifications. So it does work, and I hope that we've convinced you now that it does work, and it's definitely something useful, and it's useful to involve geriatricians in these areas. You may ask then, when should we refer? Some of you may be lucky to have dedicated oncogeriatric services already, or work within areas where oncologists are very passionate about geriatric oncology, or they are geriatricians who are passionate about oncogeriatrics. But if you don't, your local geriatric services are probably more than happy to take some of your referrals as well if you have any concerns. And you may ask, which type of patients would you like to see? I think as a geriatrician, we probably want to see our frail patients. There's a real oomph to manage frailty, and to manage frailty in the community rather than in A&E. I would say those with complexity, with biopsychosocial concerns that you're planning to treat or not treat, those present your geriatric syndromes, the falls, the kind of prevention, falls prevention, and looking into people's bone health, for example, preventing fractures. Those with multi-morbidities, maybe, that you may need help with, rather than referring to multiple specialties, maybe referring to your geriatric services, who are usually more generalists and be able to manage most of kind of conditions, most organ conditions at the kind of more basic level. And there's also an increasing argument that among oncology colleagues that maybe patients who are older, so people who are maybe 80 and above, who are undergoing multimodality cancer treatment, whether they're fit or frail, maybe they should be routinely referred to geriatric service or oncogeriatric services, because if they're not frail now, they're probably not going to be frail after you finish all your multiple type treatments. So it may be worth referring them in early on, so that they know the team and the team can follow them up from time to time and see at various points, try to optimize them for the next treatment that you're going to give them. And when you do refer them to geriatric services, what would I like to know? Well, I'm not an oncologist, so I wouldn't know all the ins and outs of your cancer treatment. But what I would like to know, at least, is what the cancer prognosis is with or without treatment, because that helps me decide how far we push a patient. So, if you're saying that the treatment extends one's life by another 3 months and the patient's actually really frail, I wouldn't necessarily be putting them through, the prehab for cancer services if it's not, kind of really going to change your prognosis. What your proposed treatment is and the intent, is it curative? Is it palliative? Because again, that changes how we manage their comorbidities. For example, if one's in their palliative stage of life, then you may not think about starting bisphosphonates, for example, in bone health, because it takes more than a year for bisphosphonates to work. But actually, if one's having curative treatment, then it's well worth investing in that. Your concerns, it'll be useful to know why you're worried and why you're sending the patients through to us. and preferably some sort of frailty score, whichever you may want to use. And in clinic, when I see these patients, I then ask myself, really, what is the life-limiting condition here? Is it their cancer? Is it the comorbidities of frailty? What matters most to this patient? Does she actually or he actually understand the diagnosis and the treatment options, i.e. a reflection of their cognition? What medications can I stop or start? And this all comes down to, is it palliative intent? Is it curative intent? Mainly around things like statins, the triple therapy, which, is using heart failure. Actually, it's probably more than triple now. It's probably like 5 different medications that they use in heart failure now. And it's balancing that against their risk of falls, their risk of polypharmacy, the cancer treatment resulting in hypotension, for example. It's balancing all that, and then around primary and secondary prevention, bisphosphonates, antiplatelets. And that all comes down again to conversation with patients about the benefits of this medication versus obviously the stage of their cancer that they are at. Does the patient have the support he or she needs? Just because one has family doesn't necessarily mean that they're able to provide all the support, and it's linking in, as Nicolo said earlier, with local services, Age UK, British Red Cross, for example, or the community crisis teams to get in all the support they need before they start their cancer treatment, preferably. And then what can I do to help? Who do I need to involve? And does any other members of the team need to see the patient? Physiotherapy, for example, OT. And that's this cartoon just illustrates the circle of drugs. I think we geriatricians find this quite amusing because we see patients that come in with all kinds of medications, and people give medications to treat side effects of other medications, to treat side effects of another medication, and you very quickly end up with this massive blister pack. So when a patient comes to me and say, I need a blister pack, I can't manage my medications anymore, rather than getting them a blister pack, I look at the medications and say, actually, what can we pick out rather than getting you a blister pack? From some of the data, I think that we have locally, questions about what other interventions we do. These are mainly the stuff we do. Medications review, by far the most, falls prevention, mobility assessment. But we look at a whole range of things where appropriate, from advanced care planning to even thinking about stopping alcohol and helping people come off the alcohol. Do not assume that our older 85-year-old frail person doesn't drink alcohol. You'd be surprised how much they drink. So we do a whole range of things. And locally, again, this is from the Wythenshawe side, where patients have usually curative treatment or adjuvant chemotherapy after surgery, for example. Just really to highlight that performance status doesn't necessarily fully assess frailty. We had in our cohort here, 67% of patients who were at risk of frailty actually were labeled as performance status 0 or 1. So just thinking about it a little bit more of a thorough assessment of frailty status. And actually the benefits of CGA maybe is probably best in chemotherapy, although I appreciate the cohort size is small here, but actually having a CGA does really help people complete their intended chemotherapy treatment. So let's go back to the case, and I've just got 2 cases to discuss very briefly. So this case, the gentleman I described earlier. So he was labeled as having a CFS of 5 and performance status of 2. He was an inpatient when the oncology team saw him, as well as myself. It was felt that given his performance status, given that he just had a stroke, actually having chemotherapy and then radiotherapy was probably going to be too risky for him. But by not doing anything and sitting for another 3 months, his cancer will then rapidly divide and rapidly progress. And the joint decision was to do it the other way around, so for him to have radiotherapy first. And the family and patient was clearly aware of the difference in prognosis with that treatment, and that was in first-line treatment for this case. So he went on to have 10 fractions of palliative radiotherapy in June. He went home, although the family was a bit concerned that he was still quite slowed down, but they, kind of his preferred place of care, and he just wanted to be at home as much as possible. So we facilitated getting him home, get some community physiotherapy, and he went on to have 10 fractions of palliative radiotherapy in June. His hyponatremia, he had demoxycycline when he left hospital. His sodium ranged between about 124 to 126. But come kind of July time, actually it's around June, July time, I don't know if you remember, it was really warm at that time. He developed some photosensitivity. So he had to stop the democlocycline. He was put down to the democlocycline. He started becoming more fatigued, more forgetful. His sodium started drifting down a little bit. So we dropped his fluid restriction from 1.5 liters to 1 liter to help with the sodium. And we maintained it for a little bit. And then come July, he had 3 falls, all put down to postural hypotension. He demonstrated a significant postural hypotension actually in clinic. His fluid restriction was lifted. He really struggled with the 1 liter. He said he felt really thirsty. We couldn't really restart the democlocycline because of the photosensitivity. He was referred to the endocrinology team for tolvaptan, but they didn't feel that it was something that can be delivered for him. So we started sodium chloride, not evidence-based, but it's something just to keep, kind of manage his symptoms really, and we stopped his antihypertensive. In October, he developed SVC and tracheal compression. He was very breathless, very wheezy. I remember this was a Friday afternoon clinic. Never ever do a Friday afternoon clinic. But he repeatedly said that he really didn't like being in hospital. His priority to remain at home. So his wife came across, collected some dexamethasone from clinic. Just bear in mind that around this time, obviously, a lot of clinics were done over the phone and video consults. So wife came along, took some dexamethasone, and we arranged for elective admission. The following Monday, that saved him 3 hospital stay days. He was very pleased about that. And he went on to have a stent. His sodium drifted down even more. His democlocycline was restarted. It was October time now. We felt that maybe it wasn't as sunny at that time, and we really needed some control over his sodium. We restarted democlocycline at lower dose. He didn't develop any further photosensitivity. And single-agent carboplatin was started at this time. He was given 3 cycles. In December, he had a repeat CT scan. It showed good response. In January, he started developing fluid overload. His sodium drifted downwards again. But we felt at this time, following the assessment, that it was due to fluid overload rather than SIADH. So furosemide was commenced. His dexamethasone was stopped. His sodium chloride tablets were stopped because that's obviously promoting fluid retention. Managed his sodium again as an outpatient. In February, saw him in clinic. He was feeling more and more breathless. I arranged a repeat CT scan for him. This showed disease progression and a very frank and honest conversation in clinic. And he reiterated his preference for staying at home, remaining at home, cared for by his wife. And therefore, he was discharged from the community palliative care team and had best supportive care in the community. I think what really the comprehensive geriatric assessment here with was preventing any hospitalization. You could imagine that I had the benefit of being able to speak to him in this 10 months, about 15 clinic appointments, a majority over the phone, obviously, a number in clinic, but preventing that unnecessary admission with maybe fatigue or tiredness or cognitive impairment that keeps being put down to his sodium, and actually being able to manage expectations and manage working very closely with geriatrics, with his GP to do the blood test and me reviewing it, and being able to get back to them fairly quickly within 24 to 48 hours just gave that added reassurance, and them not coming to the A&E department in emergency. We help with medication rationalization, symptom management, actually a wide range of symptoms. And just talking about, side effects of medication. Dexamethasone made him less fatigued, but actually gave him a mood disorder, and he was up all night. And then managing that and kind of managing that versus the fatigue. Looking into his cognitive impairment, that actually, although they reported that he was forgetful and stuff, he remained very independent actually. And then MMSE, he was only he scored something like 24 out of 30, so really only some mild cognitive impairment. And just providing reassurance, the use of community services to keep him at home as much as possible and keeping with his wishes. I think the real success is that he only had 1 admission, and this was an elective admission for SV stents. Another case that happened last week only, 72-year-old female, history of osteoporosis that was diagnosed because she had fragility wrist fracture last year, hypertension and COPD. On paper, doesn't look particularly frail. Previous hysterectomy for endometriosis. She was found to have a limited stage left hilar, small cell lung cancer, and lower third esophageal squamous cell cancer. both diagnosed very recently. She's an ex-smoker, drinks alcohol very socially, lives with her husband in a 3-story townhouse, goes out independent with her ADLs. Her medication, again, not very significant. What you would, I mean, it's not expected for a person her age with comorbidities. Her CFS was 4 and her performance status was deemed as 1. But actually, when you speak to her more thoroughly, it transpires that actually she's very low in mood. She can't really make any decisions. They were talking about treatment options, concurrent chemoradiotherapy, but she really just wants to be left alone. She felt really overwhelmed. She's lost 7 kilos in weight. She only weighs 36 kilograms now. She feels nauseated in the last 2 to 3 weeks. She's not really eating anything. She's been on pureed diet liquid, but not seen a speech and language therapist because she's still on the waiting list. Before all this, her body weight and body image has been always very important to her. So she never really ate very much anyways. And trying to tell her to drink all these 40 sips, it just adds to, kind of how overwhelmed she was. She was not really even taking it very much. She had all these boxes delivered to her house, but she was taking at most half a bottle of 40 sips a day. And in clinic, she had further weight loss, actually. She felt very fatigued. And actually, when she talks about going out every day, when you prod her further, she says actually all her life, she's always driven to the shops, walk into the shop, walk out of the shop, get into a car and drive back. So actually, she's got a very sedentary lifestyle. But recently, she's doing even less. And that's not because she's short of breath, but because her legs just feel weak and it's just giving way, but she's not had any other falls. The plan from the oncology team was for insertion of a rig in 2 weeks' time, and then to start chemotherapy, followed by radiotherapy to both lesions. But the lung cancer CNS was slightly concerned with regards to her weight and just wanted a more thorough assessment, so referred her to us. So as I said, 35.6 kilos, she lost even further weight despite taking her 40 sips, but transpires she only takes half a bottle in a day. She's not been seen by a dietitian. She's been referred to them, but there's a waiting list for her local community dietitians of something like 6 weeks. So she saw a dietitian when she came to us. We offered her appointment within a week. Our dietitians felt that she was at high risk of refeeding syndrome. She would need at least 4 40 sips a day, plus a small diet, if not 5 40 sips a day, to even build herself back up. Our pharmacist saw her, felt that her oral bisphosphonate was actually contributing to her nausea and dyspepsia, especially when she started eating very much. And her difficulty swallowing meant that she couldn't really take any of those alcohol and bisphosphonates. And because, obviously she's got cancer now, it was felt that given her symptoms, the risk outweighs the benefit of this bone health medication. So we've stopped it and said we'll revisit it at another date once she's had her treatment. She'll start on omeprazole for dyspepsia and some cyclizine. Our physiotherapy, unfortunately, was sick that day, but if not, she would have seen a physiotherapist as well to help with some balance and muscle strengthening exercises, given that she was getting increasingly sarcopenic with the lack of nutrition as well as her lack of exercise. The general consensus really was that she was in early frailty with potentially some very reversible aspects, including nutritional support and exercise. And if she carried on the way she is and waiting for a rig in 2 weeks' time, she probably will be too frail to have any cancer treatment. Any cancer treatment at that point will probably lead to high risk of toxicities, falls, she was potentially silently aspirating, and that would then lead her to having aspiration pneumonia and unplanned hospitalization. So what did we do? We spoke to the oncology team, explained our dietitian's concerns. We discussed an elective admission for NG feeding, which the oncology team was more than delighted to support. The patient was initially not keen to, but after kind of a long conversation, she agreed to that. She was brought in, her NG put in, had refeeding bloods, and the decision was then that if this NG fit was staying in, they would postpone the rig for 2 to 3 weeks after the first dose of chemotherapy so that she can be given her chemotherapy ASAP. And our team specialist nurse liaised with the inpatient speech and language therapists and physiotherapy for an assessment during her inpatient stay, and also really provided emotional support to this patient. And I think overall, she's currently still an inpatient, having her feet up titrated. We're hoping that she will do well. So really, in summary, what can we do as geriatric services? we can help with optimizing patients, providing a more thorough, because we have the benefit of time. Our appointments are an hour long for new patients. Can help with a more thorough holistic assessment and shared decision making, managing complexity and geriatric syndromes, coordinating care, especially with patients with multimorbidities and multiple specialty inputs, and preventing multiple hospital attendances, but also helping identify limitations of treatment. And I think the one thing to say really is that sometimes people feel that discussing advanced care plans means that they don't have cancer treatment, and that's not always the case. It's just maybe being frank and honest at the outset that these are the limitations, this is what you can have, and this is what you can't have. And actually that may help also a patient emotionally when dealing with their prognosis. So that's it from me. Thank you very much for listening. I'm happy to take some questions. I've got my email there as well if you wish to contact me for any other questions.
Thanks for that, Dr. Ng. That was really interesting. Some really excellent cases, and you can see clearly where you've made a difference to those patients' care. I wonder, just in the interest of time, whether we can just move on to Jess's talk. But obviously from the audience, if there are any questions, if you pop them through the chat function at the moment, at the end of Dr. Pearce's talk, we can go through any of those questions. Is that all right?
Fine, thank you.
So our third and final talk is Dr. Jess Pearce, who's a Medical Oncology Registrar here in Yorkshire. She's also an NIHR funded doctoral research fellow at the University of Leeds, looking at the role of frailty measures within cancer care. She's a trainee representative on the Joint Collegiate Council for Oncology Frailty Working Group, and is kindly going to present about some frailty assessment and some updated national guidelines. So over to you, Jess.
Thank you so much for the opportunity to present, and to everyone for sticking it out. So I, as Richard mentioned, am a current PhD student and medical oncology registrar with an interest in frailty, and I've been really lucky to be involved in this working group developing some national guidance on frailty assessment and management in oncology. And I'm going to give you a bit of a whistle-stop tour of that now. We've had some really fantastic examples of how properly assessing and managing frailty within cancer care can be beneficial from the perspective of both an oncologist and from a geriatrician. And what I'm going to try to do in this talk is really focus on how you as oncologists and whatever other professionals we have listening in that are involved in the care of older people can use frailty assessments and better manage frailty in your own day-to-day practice. So I'm going to talk by giving a bit of an introduction to what frailty is and why it matters in the context of cancer care, although that's been covered quite well already. I'll then talk a bit about the working group that's come together to develop this guidance, and then I'll go through the different sort of sections in the guidance to use that as a framework for the rest of the talk. So I'll talk about the practicalities of assessing frailty in oncology, who should be doing the assessments, who we should be assessing, when in the cancer treatment pathway, and how, so which tools would we recommend. And then we'll talk a bit about management of frailty, but that's been covered really well again already. And I'll briefly touch upon the importance of audit, service improvement and research in this area before giving you a bit of a taster of what recommendations are emerging as we've been developing the guidance and the next steps. So what is frailty? I think we've kind of touched upon it, but a definition is that it's a syndrome with multiple causes and contributors characterized by reduced strength, endurance and physiologic function that increases an individual's vulnerability. Or put simply, it's an increased vulnerability to stresses on the body. And as you know, our treatments can be really toxic and they can be one such stress. So here on the bottom right-hand side, I think this diagram shows really nicely what frailty is. So you can see how when a frail patient experiences a stressor event, they're more prone to a bigger deterioration, they're less likely to improve back to their previous level of functioning as quickly, and less likely to bounce back to being quite as well as they were before. So why is it important in the context of cancer care? Sorry, my screen's trying to go to sleep. I think it's trying to tell us it's all time to go for dinner. So we've already heard that we've got an aging population. Sorry about this. My screen's clearly decided that it's the end of the working day. I'm just gonna screen share on my main screen. It should only take me 2 seconds, bear with me. Hopefully you can see that and the pictures of people aren't getting in the way too much. Okay, so yeah, we've already heard that we've got an aging population. most of the people diagnosed with cancer are older, and frailty is really common, particularly in older people, but not exclusively in older people. So frailty does affect younger people too, and it's associated with worse cancer outcomes. So as you'll have seen in your own clinical practice, patients with frailty are more prone to side effects from chemotherapy, surgical complications, and death in the course of cancer treatment. So it's really important that we take account of frailty, as we've heard, when making decisions about cancer treatment and looking after patients. And we've seen lots of graphs. I think this is pretty much the only one I'm going to show you today, which essentially shows how cancer survival varies in different age groups across Europe. And perhaps unsurprisingly, you can see that cancer survival adjusted for different variables is worse in older patients, and perhaps to some extent that's expected. But what I think is quite shocking is how much worse survival in older patients, particularly those aged over 75, is worse in the UK and Ireland compared to elsewhere in Europe. So we really have some work to do here in the UK, particularly when it comes to optimising care for older patients with cancer. So when we talk about assessing frailty in cancer care, what are we trying to achieve? Well, in the guidelines, we outline two broad aims. First of all, to better assess the risks and benefits of anti-cancer treatment to inform shared decision-making with patients. And again, I think that's been covered and the rationale for that really well already. And then secondly, to allow identification and optimisation of frailty-related issues. So learning from the principles of what our geriatric colleagues have been doing so well for such a long time, and using that to improve patient symptoms, quality of life, and again, as we've seen, and really importantly, patients' tolerance of the anti-cancer treatments we give them, because we know that they're proven to improve outcomes. So a little bit now about the working group. It's been headed up by Anthea Cree, and she, as we've heard, is the lead for the British Geriatric Society Oncogeriatric Special Interest Group, alongside Cassandra, I believe. And we've got representation from national experts in this area, representing a number of different national bodies, and it's hopefully going to be published under the auspices of the Joint Collegiate Council for Oncology, which represents both medical and clinical oncologists. And it is primarily aimed at oncologists, but it would be relevant to anyone that's involved in looking after older patients with cancer, which is most specialties really, and our multidisciplinary colleagues as well. So moving on now to the practicalities of assessing frailty in oncology. Who should we be assessing? Well, we already have broad consensus, as we've heard from the American Society of Clinical Oncology guidance, that we should be assessing all over 65s who are being considered for systemic anti-cancer therapy. But recognising that frailty can also affect younger people, and particularly those with cancer and other comorbidities, we do think and recommend in the guidance that we should be thinking about frailty in anyone that we're considering for cancer treatments. In terms of who should be undertaking the assessments, essentially frailty is everyone's business, and we should really be utilising the skill set of the whole MDT when assessing frailty in the whole cancer treatment pathway. And there's lots of training out there to upskill different members of the MDT, which I'll signpost to at the end. When in the cancer treatment pathway should we be assessing frailty? Well, a key message in the guidance is that every single step along the pathway is an opportunity for assessing frailty and considering it within decision making. And ideally, we should be bringing frailty assessments in as early as possible. But as a bare minimum, we would suggest that frailty should be assessed prior to MDT discussions and feed into decision making at that time. Obviously, we already use performance status, but we know that that's not very well recorded or not very accurately recorded. And we also think that as a minimum, it should be considered alongside decision-making in oncology clinics when we're making decisions about systemic anti-cancer treatments. And we wouldn't suggest any hard or fast rules about treatments that should or shouldn't be given to patients with different levels of frailty or specific cutoffs. But similar to the slides that have been presented by Cassandra, we would suggest that at different levels of frailty, it might reframe how we think about managing patients. So, for example, in the fittest patients, we'd be giving them usual care, but we'd also be wanting to address reversible issues such as sarcopenia, problems with nutrition. In patients that do have a bit of frailty, we'd be more actively seeking out and managing frailty-related issues such as falls and cognitive impairment, polypharmacy. And we'd be prompted to think about getting the input from our geriatric or oncogeriatric colleagues where those links already exist. And I definitely encourage people to think about making links if they don't. And then in patients that are more frail, we might reframe the goals of care, so thinking more about quality of life rather than achieving cure, and it might prompt us to start thinking about advanced care planning with support of our palliative care colleagues, again alongside getting input from our expert geriatric medicine colleagues. So how should we assess frailty? Well, in an ideal world, and we've seen how fantastic a comprehensive geriatric assessment can be to understand the full range of frailty that a patient's experiencing. But in reality, with limited time and resources, simple frailty assessments are a really good place to start, and they can help us both to provide a bit more information to inform decision making, but also to identify patients that are more likely to benefit from more comprehensive frailty assessment and management. But I would absolutely emphasise that there's no point in assessing frailty if we're not going to act upon it. So whilst I'm going to spend most of my time talking about assessing frailty, we do really emphasise the importance of management as well in the guidance. So what tools should we use? Well, there's a number of different tools out there that can be used to complement the assessments that we're already doing in oncology when we're assessing patients and making treatment decisions. And I don't have time to go through all of them, but some key examples are the clinical frailty scale and the Geriatric 8 screening questionnaire. But there is also the SAOP3 screening questionnaire, which we heard about from Nicolo earlier, as well as the Vulnerable Elders Survey 13, which is a patient-reported questionnaire based mostly on functioning. And there are also automated frailty measures like the Electronic Frailty Index, which are pulled from routine healthcare data. And what I'm going to do now is just talk a bit more about the clinical frailty scale and the G8. So the clinical frailty scale, I'm sure many of you are familiar with it already, but essentially it involves assessing a patient's day-to-day fitness and functioning on a scale from 1 to 9. And it's really quick and easy to undertake. It's similar to performance status, as you can see, but it's more granular. There are more categories and there's much more detailed descriptors to help place patients more accurately within the categories. It's really widely validated and used cross-specialty, so I think it's got a lot of potential to be used as a cross-specialty language for talking about frailty, for example, with our surgical colleagues and other specialties. But as you can see, it does only assess a single domain of functioning. It doesn't touch upon other areas of frailty. And up until recently, there's not been a huge amount of data looking at it specifically in oncology settings. But there is data coming through, so I wanted to share this here, which is from a paper that's been published within the last few weeks from the team in Newcastle. And essentially, they looked at care needs and survival after hospital admission for patients with cancer. And you can see how there's a really good correlation between clinical frailty score and survival following discharge, including in their total population, but also in younger patients, which is really interesting because these tools were initially developed and have only technically been validated in older people, but they might still have some potential to supplement our assessments in younger people too. And again, this is some similar data from Manchester here. This is the outpatient setting. In Manchester, they've been using clinical frailty scale in their lung clinics, going back, I think, to 2018. And you can see the incidence of frailty on the left-hand side. So 40% of patients, and I think this is across all ages, were categorised as frail with a clinical frailty scale of 4 or worse. And you can see on the right-hand side how patients with frailty versus those that are fit, again, have worse overall survival. And then moving on to the Geriatric 8. So as I mentioned, this is an 8-item questionnaire which looks at a few different frailty domains. So it covers a bit about functioning. There's quite a few questions about nutrition and some other bits and bobs as well. This is really widely validated in oncology, and so it's recommended in the ASCO guidance on managing older cancer patients because we've got a lot of data to support it, basically. It's multi-domain, as you can see, but it is quite nutrition focused, and that leads to a bit of a concern that it could overestimate frailty, particularly in GI patients. But there is some data coming through suggesting that using a lower threshold might allow us to have a bit more specificity. And it is a bit more involved, but you do get more information from it as well. So we've spoken a little bit about the different frailty assessment tools. I think a key message from today is that there's lots of different tools out there. It doesn't really matter what you use. You kind of need to weigh the value added from the assessment with the feasibility of applying it in your setting, and just use something as a starting point. And then you might go on to build what you do and add some other tools in as you go, as you start to see the value of it. And then once we've done a simple frailty assessment and identified a patient's potentially frail, we would suggest going on to a more comprehensive frailty assessment. And we've heard today about how integrated oncogeriatric services and geriatricians can do fantastic comprehensive geriatric assessments where they assess the different domains of frailty, identify problems and manage them. But I do think that there's some of those principles that we can apply within the oncology clinics just to do a little bit of a better job of providing holistic care to people. And I just wanted to share this table, which is included in the appendix of the guidance as it stands at the moment. And essentially what this shows is down the left-hand side, the different domains of frailty. In the middle, we've summarised the different tools that are recommended for assessing those domains in the existing guidance from ASCO and CEOG. And then on the right, we've suggested where different members of the MDT might have a role in supporting the assessment and potentially the management of a patient with a problem in that domain. So, for example, a physiotherapist or occupational therapist would be particularly well placed to assess functioning and manage any issues related to that. And a pharmacist would be much better placed than we are to assess and manage polypharmacy. So it just emphasises the importance of utilising the MDT. So again, we've touched quite a lot on the management of frailty in oncology. I just want to draw back to those two aims at the start. So when we're assessing frailty, we want to use it within systemic anti-cancer treatment decision making, and we also want to make sure we're managing reversible frailty related issues. And when we talk about informing decision making for cancer treatment, we're wanting to minimise both under and over treatment. And when I talk to people about using frailty in cancer care, I hear anxiety on both sides of the spectrum that patients are going to be denied treatments, or that people are going to be pushed to treat people that aren't necessarily appropriate for treatment. But it's really about trying to better stratify patients and get the right treatment for the right patient. And again, we've seen this slide earlier from Nicolo, but I just wanted to highlight how there are some simple things that we can probably all make a bit of an effort to do a bit more proactively in our day-to-day practice, like trying to better optimise people prior to treatment by giving them advice about being a bit more active, getting their GP involved in managing comorbidities, if they've got cognitive impairment, limiting the complexity of treatment. You know, this is stuff that we're already doing already, but almost certainly we could do it a bit more, basically. And the ultimate goal of all of this is to improve outcomes for patients. And Nicolo mentioned earlier about the randomised control trial evidence coming through, but I've just summarised it on the slide here. So we've got 3 RCTs now, and I think there's actually 4. Nicolo mentioned the GAIN study earlier as well, where patients that are older, undergoing chemotherapy, have been randomised between having geriatric assessment and interventions or standard care. So all of the patients had chemotherapy, but they either had geriatric assessment and interventions or not. And we've seen evidence of reduced grade 3 to 5 toxicity, improved chemotherapy completion, and better health-related quality of life. And with all of this evidence coming through, it's really hard to justify this not becoming standard of care. But obviously, we've got a lot of work to do to build capacity for that. And that's where the importance of audit, service improvement and research comes in. So I'll keep this really brief, but essentially we need to be doing audit and service improvement to demonstrate clinical needs, so to show how many frail patients we've got, to evaluate changes that we're making to try and improve care for these patients, and also to bring together the evidence to build business cases for the funding that we need to further develop services. And again, we've already touched upon this today, but we need to make sure we're changing the way that we deliver clinical trials to make sure that they better represent the real world, so that we can use the evidence that we've got to inform the care of older patients, which is really hard at the moment. Okay, so moving on to the recommendations from the guidance now. So the ultimate vision is that across the country, Tailored services will be developed to meet the needs of frail and older people with cancer that will be patient-focused. It'll involve strong clinical leadership of multi-professional teams with strong working relationships between oncology, geriatrics, and other members of the MDT, with clearly defined pathways for onward referral, comprehensive data collection, and ongoing service improvement and development. And we give specific recommendations at these 4 different levels, so national, regional, local, and individual. I don't have time to go through all of it, obviously. Everyone wants to go get their dinner, but I will give you a brief snapshot. So at a national level, we think that the needs of older adults and frailty should be considered in the National Cancer Plan. We suggest that clinical frailty scale, as the simplest frailty assessment that's available, should be a key performance indicator, and that everyone looking after older patients with cancer should have some training in frailty and geriatric oncology, and that should be integrated within undergraduate and postgraduate curriculums. And that then at an individual and local level, we think that frailty should be assessed prior to the MDT and when planning systemic anti-cancer treatment and radiotherapy and any other cancer treatments that people are having. We think that frailty should be considered in decision-making and that we should be working to optimise reversible frailty-related issues as part of holistic care. And to achieve that, we need to involve the whole MDT and link in with our specialist geriatric colleagues. So moving on to the next steps, I don't have too many slides left now. So we had some feedback from the last Joint Collegiate Council of Oncology meeting, and we're working on revising the guidance before putting it out for stakeholder consultation to all these groups you can see on the right. And then it'll go back to the JCCO for a final review before hopefully being published in the spring of 2023, if we manage to get all of that done on time. So I just wanted to flag a few resources. There's lots of different places out there with a wealth of information about frailty where you can get different, options for, learning more, and it might be worth checking these out afterwards if you've got time. But the key points that I want you to take away from, I think, all of the talks that you've had today, and particularly this one, is that frailty is really common. It's associated with worse cancer outcomes. Recognising frailty is an essential step towards optimising care for an ageing population. And there's lots of different tools out there that can be used to assess frailty. Try not to get too bogged up in the details. If you don't know where to start, the clinical frailty scale is probably a good starting point. And I hope that when people see the value of that, they'll start expanding their repertoire and potentially using other more complex tools within their care pathways. Frailty should be assessed early with 2 broad goals: improving the assessment of risk and benefit within treatment decision-making, and also allowing us to optimise frailty-related issues and improve patient outcomes. And to succeed, we need to engage and upskill the whole multidisciplinary cancer team, and again, work with our expert geriatric medicine colleagues. And that's it from me. So thank you all so much for listening. I will stop the screen share, and thank you as well to all of the rest of the group that have been involved in developing this guidance.
I think it's been an excellent set of talks, and I don't think there's any doubt that this is really essential now. And I've taken away some really useful things about what I might apply. I'm in a hospital at the moment that has quite an elderly population, and I think this is really useful for my clinic tomorrow. There's 2 or 3 patients I know that would benefit from some of this, so I might start doing some of this routinely, and I'm sure other people will as well. So thanks for that.
They can always drop us an email as well if there's any other questions.
Perfect. Well, thanks to Dr. Battisti, who had to leave early because he has other commitments, as I'm sure you're aware. Thanks to Dr. Ng and Dr. Pearce, some really excellent talks, and so thanks everyone for your time, and I hope you have a good rest of the evening.